October is Health Literacy Month, and a lot of the programs that we're having during the month are health related, and tonight's program is no different. Some other things that are coming up on October 23rd, Home Instead Senior Care is going to be doing a program on Alzheimer's family education to understand Alzheimer's disease and other dementias. On October 24th at 1:30 in the afternoon, we're going to have a program on slow cooker cooking, comfort foods, and that's going to be presented by University of Illinois Extension. So they're going to talk about healthy choices that you can make in your slow cooker. On the 24th, again, at 6:30, we're having a program about healthy relationships done by Freedom House, and they're going to talk about, you know, healthy versus abusive relationships and the resources in our community that can help you, and just places you can go for help if you're in that situation. On the 30th, there's going to be a program on blood donation and its importance. Mississippi Valley Regional Blood Center is going to be here, and they're going to do blood typing. If you don't know what kind of blood you have, you should probably have it typed. And they're going to talk about how your donations that you make of blood, how they really can transform a person's life, you know, and how helpful they are. On the 27th, we're having our Health Happens Expo. This is probably the third or fourth year we've done this. And there's going to be different health groups in the main area of the library. We have Perry Memorial Hospital. We have Country Comfort Retirement Home, Liberty Village, Freedom House, University of Illinois Extension, Vitas Hospice, Home Instead Senior Care, St. Margaret's Hospital, Genesis 129, and Mana Health. And as of today, we're also going to have CPASA is going to be joining us. So one comment that people made in the last couple of ones that we had was they said, you know, you go online and you check information and you check 3 websites and you get 3 totally different answers to your question. And the patrons of the library really did like that they could come here and ask an expert and dialogue with them and maybe get a more refined and local answer. So if you've never been to our Health Happens Expo, it's a good place and a good resource to get lots of information. We have other programs here that aren't health related. We have a music jam on the 23rd. So if you play an acoustic instrument, like a guitar or mandolin or something, and you want to play, just come and play, jam with the group. Or you can just come and listen. It's not threatening, no one judges you. It's just a fun time to just get out and have fun. We're going to have our 3rd month of our Princeton Rock Painters. And what it is how many of you have walked around Princeton, like in the parks, and found little rocks that had little notes on them, little inspirational messages? Well, that's done by this group, and they meet here once a month, and they print these, they paint these little rocks with little cutesy little designs or inspirational words, and then they hide them for you to find. So if you want to be part of that, that's going to be on Thursday the 25th. And if you do want to come, make sure you register at the circulation desk because we have to make sure we have enough materials. We also have Monday night movies every Monday night on the big screen. The next 2 Monday night movies we're going to show are Sabrina, the 1995 version, and The Day After Tomorrow. So if you like an apocalyptic movie about what happens when the Ice Age is coming, that might be a good one to watch right before Halloween. Our November calendar just came out, so if you collect these and take them home to know about the programs, they just were printed today. Just 1 or 2 things I wanted to mention. We're having our book sale, our fall book sale on the 8th, 9th, and 10th. And the money that is raised from that supports the programming at the Princeton Public Library. So, and if you've ever donated books to the library book sale, we'd like to thank you also. Okay, I'd like to introduce Lindsay Vaughn, and she's going to talk about our program tonight, okay?
Thank you.
Good evening, I'm Lindsay Vaughn, and on behalf of Voices from the Prairie, welcome. Voices from the Prairie is a transpartisan organization focused on civic education and engagement. In recent weeks, much of our programming has focused on the referendums and candidates we'll be voting on in the upcoming election. But we also aim to explore the wide-ranging issues that impact our lives, our families, and our communities every day. Sometimes these issues do impact the way we vote, but being a good citizen involves much more than casting a ballot on election day. One of these issues is healthcare, and we as a group keep returning to this as a program topic because it affects each of us, and there's always something new to learn. Many thanks to Princeton Public Library for taking on the task of promoting Health Literacy Month and making so many great resources and events available to the public. We're honored to partner with them tonight on this program. We're joined now by Perry Memorial Hospital President and CEO Annette Schnabel. Ms. Schnabel came to Princeton in 2014 and served as Vice President and Chief Operating Officer at Perry Memorial prior to assuming her current role in 2016. She was recognized just today as a woman of distinction, and we congratulate her on that honor. Tonight she's going to be bringing us up to date on what changes are coming out of Springfield and Washington, D.C. that affect us and our healthcare here in the Heartland. She'll be reviewing the Affordable Care Act, discussing which aspects of the ACA have been maintained, which have been repealed, and which are still being considered for repeal, and covering other recently approved and pending healthcare legislation at the state and federal levels. Ms. Schnabel, thank you for making the time to be with us here and bring us up to date tonight.
Thank you. So I'm not sure the mic's really working, but I do think that I probably project well enough so you probably can hear me, and if not, there's room. We've got a great crowd tonight. And first, I have to comment. We're decorated for Halloween evidently here, even on the picture.
I hope so.
I was looking at that and I thought, what the heck is that? And then I realized what it was.
That was the first mayor of Princeton on the right.
Yes, and he's got his mask on and he's got a wolf tooth or something hanging out there. So anyway, as she said, I'm Annette Schnabel. I'm the hospital's president since 2016. I've been in healthcare for 30 years, started out as a physical therapist and have done several other different roles in healthcare. And I'd also say I'm not your expert on everything that's happening from a government-wide perspective, but hopefully I've researched and keep up on enough information that I can get you some good information tonight, and then probably spur more questions that we maybe need to get answered. And I have Voices of the Prairie, so I'm sorry your Voices from the Prairie. So I need to fix my title slide there for you. So I have, I think, probably about 25, 30 minutes worth of conversation, but I also get told that I talk fast, and so if I'm talking too fast, please slow me down because that'll probably shorten it unless you don't want me to shorten it. You want it to keep it going faster. I'm actually going to start out with the federal conversation first and then move into the state, and I'm going to talk a little bit about the Affordable Care Act, but some other stuff that happens as well, not just the Affordable Care Act. So we'll start with that and go ahead and do a slide. And the first, one of the things I like to do when I work with my staff is let's talk about why. Why are we even having this conversation? Because numerous polls are showing that healthcare actually is one of the #1 issues for our voters again this year, even though we're kind of at a different state than what we were before. And this issue, one of the main issues that we're hearing about is what's happening with pre-existing conditions as far as the Affordable Care Act is concerned. And this is an actual poll that just came out, information on today. Healthcare, again, being one of the top issues for voters, which is rated at 71% saying it's a top issue. You'll see other things such as the economy and jobs, gun policy, immigration, etc. Among the healthcare issues, though, the largest share of voters say they are hearing a lot about the prescription painkiller epidemic, so the opioid epidemic we're all hearing about, the Affordable Care Act again, and then also wanting to make sure that we're hearing about pre-existing conditions. Fewer voters say they're hearing a lot about the National Health Plan, the Medicare for All. I will address that for you a little bit tonight. And then in addition, 66% of voters say candidate support or opposition to President Trump is going to actually affect their decision. So this could get interesting. So one of the first things, when we go back to the idea of keeping the ability not to be penalized for your pre-existing conditions as an opportunity for us, we know that what the Affordable Care Act put into place, because that was included in it, was other ways to help the insurances and et cetera be able to provide insurance to people who had pre-existing conditions through certain funding methods. Some of those methods have now been taken away based on changes that the current administration have put in place. So just going back from the Affordable Care Act, what we see in the research shows us that actually healthcare premiums have been on the rise, had been on the rise long before the Affordable Care Act actually went into place. It's one of the reasons why it needed to go into place because right now healthcare spending is about almost 20% of the GDP, continues to go up, and we need to figure out where it needs to be capped and how we're going to cap it and be able to have a good economy. So we know it was on the rise. Many people through the ACA obtained coverage for the first time. We saw uninsured rates drop from 18.2% down to 10.3% or so, giving us some pretty exact numbers. Again, a lot of my information there coming from the Kaiser Family Foundation. So, okay. And they're also saying, so one of the other aspects of the Affordable Care Act was what's called the marketplaces. Marketplaces where private insurances could be bought from people who were not employed or on Medicare or Medicaid. And some of the marketplaces were supported by the federal government, so a person who qualified based on their income could actually get support to pay for their premiums through the marketplace. That's been one of the challenges we've been seeing happening with the current administration. First, they pulled the funding that was there to support that got pulled, and then it most recently just has been put back. But the Kaiser Family Foundation indicates that that actually is stabilizing. We found they're seeing that the individual market rate medical loss ratio has decreased. So again, medical loss ratio related to how much premium versus how much spend is actually happening. And so that's down, which is a good thing. And then the average individual market gross margin per member, so this is telling us the insurance companies are making more money currently, is up. So we see where it was in 2015 and then up to $155 up now per month per member. And then it's also showing that the average premium per month per individual market member and versus the claims. So this is saying that the insurance companies are actually in the marketplace are currently making money. The other piece about it is the average number of hospital patient days per 1,000 has gone from 21 in 2011 up to 27. So it's actually increased. So that's telling us some of those people are going to the hospital maybe that weren't going to the hospital before. So accessing care. That's what we're seeing from the marketplace impact. Also, this year, what we're expecting is rates are going to be actually decreasing in Illinois. That does vary based on where you live in the state. So this is what the expectation is for 2019, that we're going to see an average of 4% rate decrease for those silver plans that are available, an average 3% rate decrease for the second lowest cost silver plans, average 6% rate decrease for the lowest cost gold plans, and average 6% rate increase, though, for the lowest cost bronze plans. Again, this varies by county, and I'm giving you an example depending on where you live. Cook County versus St. Clair County does impact that. So it's not consistent necessarily across the state. Most areas of our state will have two options in the marketplace. That's also one of the things we hear a lot in the media. People don't have options, they don't have choices. And so we'll see here, Cook County, DuPage, Kankakee will have 3. Carroll, DeKalb, Joe Davies, Lake, so there's just a few, and Lee is very near us. We'll actually have only 1, but all the others in the state will have 2 options available to them. So there are still some restrictions available in some areas, but not as bad as maybe we sometimes hear being stated. So the election is heating up. We do believe that, or I'm not saying we, but what I'm reading and stuff is that this is a referendum on the opinion of President Trump. With a high number of Republicans retiring, the chamber could switch hands. I saw a thing on the news this morning that there's a lot of variation yet because there's a lot of races that are very close. But it's potential to move to a Democratic majority in these one or both of the houses, or it's still possible that Republicans could maintain control of the houses. So it's very much still up in the air as to what's happening. Some of the big races are listed there, Davis being one of the ones that's probably closest to our region. But again, that issue with the pre-existing conditions is a hot button item. And so we'll see what people are saying about that. So I don't usually like to make slides with so much data, but I'm quoting a lot of people, so I wanted to put their data in here. But again, federal-wise, Democrats we're planning to look at a vote in order to push the idea that we need to keep those pre-existing conditions. Basically, their intention is to push this so that the Republicans either got to vote for it or they're going to be able to use that against them as they finalize the last campaigning. So kind of is their strategy on this. Republicans are arguing that the plans provide so the Republicans, what you've seen Trump do is put in place some temporary plans. Under the Affordable Care Act, if you lost your insurance and bought a temporary plan, that plan can only be so many months long because those plans are not required to give you minimum coverage that was defined in the Affordable Care Act. So that was one of the things that the Affordable Care Act did, was it put in place basically defined what you were buying. So buying a gold, a silver, or bronze, you knew what you were getting, you knew what kind of coverage you were going to get. These temporary plans do not have to meet those regulations. So one of the things that's happened under the Trump administration is those temporary plans, instead of limiting to a couple months that you could have them, you can actually basically have them for the whole year. I think one day less, maybe, something of that nature. So basically, you can have your coverage through these plans and not have that minimum benefit, which is a challenge to people maybe not understanding that they're not really going to have that full coverage, and then is it really fitting the whole expectation? So, but then so the next part of it is then the Republicans arguing that the plans that they're having in place provide cheaper options. Yes, they're cheaper because they don't provide as much coverage. So that's obviously. And so in addition to those short-term plans, they've also created some new where people can pool in together. And again, those are not held accountable to the Affordable Care Act regulations. So therefore, again, those plans do not have to provide the same minimum coverage. So that's just something that's happening that, again, it has changed from the initial Affordable Care Act under the current administration. Okay. So of course, what we hear as people are out there campaigning, and since actually the previous election, we hear a lot about repeal and replace, or we hear about repeal. So it's interesting because what we're seeing from an actual legislations that they're putting together and enacting, they're saying we want to keep pre-existing conditions, we want to keep these good components of it, but yet they put together legislation that maybe interferes with that actually being able to happen. So numerous Republicans who are supporting attempts to dismantle Obamacare are at the same time campaigning that we need to keep the core provision of the law, which is that pre-existing condition piece. It's actually in some conservative states, it's put some Republicans and swing House districts on the defensive and giving the opening for some of the Democrats to come in and challenge them better. So I keep going back to this pre-existing conditions because that's really one of the top things that's being talked about right now. But so this is actually receiving bipartisan support. Both Republicans and the Democrats say this is an important thing. They understand that we want to try to protect those people who have the pre-existing conditions. However, in our the budget, the tax document or whatever tax bill from last year, it took away the funding of the individual mandate. So even though that's one of the ways that we were supposed to be paying for, people don't have that kind of coverage. It maybe doesn't happen now. But what happened with the most recent budget pass is it's back to focusing on our border security. So this is, I'm going to take a step away from the ACA a little bit and talk about some of the new different legislation. And so this first one is related to the opioid epidemic. So we've identified there's a major issue in our country related to opioid abuse. And so they put together a legislation. This last I read, he hadn't signed it yet, but I think he did. Anyway, these are the things that this legislation is going to address for us. It's going to have Medicaid coverage for former foster youth, maternal and infant substance use disorder, access to telehealth. That's one of the things that I'm actually excited about coming out in the bills is the access to telehealth. As a rural healthcare provider, there's a lot of specialties we can't bring to our community. Mental health, behavioral health is one of those. We actually currently now have those services brought to our community via telehealth, but under the old rules, Medicaid wouldn't necessarily pay for that, and under new rules, that's actually going to be coming forward. CHIP, which is the Children Health Insurance Plan, has behavioral health coverage mandate, Medicare coordination coverage for the opioids, prescription drug monitoring program. That's something that's been put into place as well. So our state has a database where we need to check people's prescriptions and their filling of prescriptions before our doctors prescribe additional prescriptions of a certain level, certain stage levels of that. And so that is something that's been put in place. They're looking at grants to be able to also work on, again, community healthcare outcomes. We're going to look at pain management, medication-assisted treatment administration. This is also a program that we do offer at Cary through Prompt Care. So people who have an opioid addiction, we do have medication-assisted treatment available. One of the things with that program, those physicians who prescribe the medication and treat patients are limited on the number of patients that they're allowed to treat. So the first year that you're a prescriber of this, you can treat about 35 patients, and then it goes up to around 100, and then a little bit more than that. So the provider that works for us actually is the highest level currently, but this new will actually allow him to even see more. So instead of limiting it to that amount that we're getting limited to right now, we'll be able to actually provide more care for those patients and under that, his license. And then, of course, they're looking for alternatives to opioids and how do we have abuse deterrence and prevention. So this is a positive thing that has come out from the opioid epidemic that we're having as far as from a legislative perspective. This one is also, this one is not passed. This is a proposal. It's called the Rural Emergency Medical Center Act of 2018. Similar bills like this have come around several times in the last several years, but none of them have been passed yet. But basically right now, in the rural areas, you have critical access hospitals, which is what Perry Memorial is. Critical access hospitals are limited in the number of beds that they can have in their facility, so 25 beds. We have a limit on the length of stay and different things that we are required to have. So us, as well as other small hospitals under 50 beds, would be able to actually convert to emergency departments and outpatient services and receive actually increased funding for that care. So the idea is, one of the things that we've been hearing a lot is closures of rural hospitals. So mostly the places where we have seen closures of rural hospitals has been in states that did not adopt the expanded Medicaid. So mostly the Southeast, but there has been some other locations as well, as far as rural hospitals closing. So they're proposing legislation to allow rural hospitals to basically eliminate their inpatient care. We at Perry are 86% outpatient care. So if this were something that would apply to us, I mean, we could choose to do that. We would not be able to have inpatients, but we'd be able to keep our emergency, we'd be able to keep doing surgery and other outpatient services. The proposal actually would be to pay more than what they currently pay now to be able to have this type of hospital. So again, if they pass this, doesn't mean a hospital has to do it, but it does mean that would be an option to a hospital in the future. Kind of switch a little bit. So the 340B drug program is a program that allows certain hospitals that provide care to a certain percentage of people with lower income to be able to get drugs at a cheaper price in order to be able to treat those patients. So for us, we use the 340B drug purchasing program, and we save about $500,000 a year on purchasing of medications, and these are high-cost medications that are typically used for people, for us, it's typically used for people who have rheumatoid arthritis. Some of those drugs are very, very expensive, and they have to receive them via IV, so we treat those kind of things, sometimes chemo drugs. So we use the 340B drug program to save money in order to be able to use our money for other programs. So one of the things that we've been hearing from our federal government currently is that they're trying to cut this program. They don't want to have, and it's actually partially funded from the actual drug companies themselves, and it's like a pass-through. But basically, we are lobbying now to try to keep this, and there's been a lawsuit filed to try to keep that as well. So not necessarily a current, it is legislative stuff, and they are trying to change it, but there's also judicial stuff happening with it as well. So what we're looking at, because they, one of the reasons why they keep talking about cutting the 340B program is they think maybe there's abuse in the program. There's abuse anytime in a lot of stuff, but we don't know where that abuse is. So one of the things that we're saying is, rather than just assume there's abuse, let's make some more transparency so you can identify that those of us who are using it appropriately can continue to use it. So what recommendations we have is we want to make sure we're communicating what the 340B program does to hospitals like us. What are we able to do because we got that rebate? So what is the savings that we're getting? And then we have to have oversight of the program, and that's one of the things that why they think there might be abuse is actually at the federal level there is an assigned overseer of the program. They're really not doing probably a good job of doing that. So we would want that to happen, that there is that oversight, and we would be willing to be transparent because we feel that we're doing the right thing based on what the regulations are and what it does for the people in the community that would not otherwise be able to access that care. So we're going to talk a little bit, skip to the Medicare for All conversation. So as we look at, we hear the repeal, replace, that's what we hear from the Republicans most often, and then what we hear from some Democrats, and it's growing actually, about 60% of the caucus is suggesting that might be a way to go forward in the future based on certain bills that are released, not on Bernie Sanders' bill, by the way. So because of that, I wanted to kind of bring that idea in. When I mentioned who's running locally, one of our local state representatives, actually the incumbent, is saying repeal, replace, and his challenger is saying Medicare for all. So that's why I wanted to bring this forward. Again, I'm not advocating either one. I'm just telling you what's available. So during the last election, Bernie Sanders came out saying he wanted to go to Medicare for all or the single payer system. In his version, the U.S. government would be a single payer. All Americans would be eligible to participate. It would eliminate private insurance. It would expand coverage by including dental, vision, and long-term care. His plan had a 4-year go-live plan, basically starting with people 55 and then rolling it in. And basically, I want to say that saying Medicare for all is a little bit of a misnomer because as a single payer system, because Medicare actually is not truly a single payer system, and there's 2 reasons why. One is Medicare Advantage plans. So you have traditional Medicare, and then you have Medicare Advantage. Medicare Advantage plans are HMOs. They're health HMO type products in which the federal government actually pays the insurance company the premium amount that they would have from the people that are enrolled, so that those insurers can then also sell it to the person and give them a benefit. And the Medicare Advantage plans often include a dental or a vision, will have other wellness type things in it. So 1/3 of the Medicare beneficiaries are in Medicare Advantage plans rather than the traditional Medicare. The other piece about calling Medicare a single payer system is there's actually the Medicare, CMS, contracts with private insurances to actually administer Medicare. So when we, as Perry Memorial, get paid for our Medicare patients, we're actually submitting bills to WPS, Wisconsin Physician Services is actually the name, and that's how that is getting processed. So it's really not truly a single payer system. And yes, the funds come from the federal government to them, to us, that type of thing. So, so it's kind of a misnomer. He didn't really receive co-sponsors at first. I think the most recent I saw said there were 16 people maybe had signed on to his recommendation. A private entity did an analysis and said that his program would cost $32.6 trillion. Bernie's response was that that's $2 trillion less than the current system. So that's what the numbers, and again, those are, the price tag came from his opposition, and, but was verified by a neutral third party. So, will that work? Will it not work? It's hard to say. So next slide on that. So then, because that kind of started, the idea of Medicare for All started to get rolling, there's actually a House bill that came out as well. It's called House Bill, I think it should be an HB instead of HR, 676. This one actually has 121 co-sponsors as of this month. This one also includes dental, vision, long-term care, and mental health as well. This one has a 2-year Go Live plan, basically rolling in over time. This one they want to fund with current revenues from the federal government, which basically means monies that's currently being appropriated to Medicare, Medicaid, and the CHIP program would be to fund this program. In addition, they would have a tax increase on the top 5% wealthy people, as well as a progressive payroll tax. So that's how they would want to fund this program. Let's go to the next slide. Oh, sorry, go back. I thought I had some other information in there. Anyway, so that's that idea. That's one of the bills out there. So now go back to the next slide. Okay. So there is actually, since then, though, a whole bunch of other ones that are being proposed. So I'm not going to go through all the detail, but there's one called Medicare X. There's the one called the Choose Medicare Act. The one that's called the Medicare at 55 Act. So basically, you get into Medicare at 55. The Choose Medicare one is anybody in the United States could choose to go into that program. There'd be a premium situation, and then the Healthy America program. Again, these are all these different single-payer concepts or availabilities that are coming out since we've started the initial proposal that came out from Bernie Sanders. So the thought process is changing in terms of do we go from current system to something different. The thing is, go to the next slide. It really would be a very rough transition. I'm not saying again whether it's good or bad, but it would be very rough because of the way the current system works. Right now, I mentioned in the current system, private firms process most of the Medicare claims now anyway. And if they were to go to a single payer system, they probably would still be doing that as vendors of the federal government anyway, so there would still be, because if you think about it, think about our economy and all the private insurance companies, and they're all on the stock exchange, etc. So if we went to a single payer system, what happens to all that? Because it's not just a simple make a switch thing. There's a lot of thoughts that have to go into how does that all roll out in our economy in general. So that's what their thoughts are, is that if we did go to that single payer system, those people who are in private insurances now would get to be a vendor for Medicare, for the federal government, basically. Put another slide on it. So what's the impact on us as taxes on us as consumers? Well, they're really funding of it, even though they brought some stuff, it's still pretty unclear. Would actually, if we were to go to a single payer system like this, would require the largest tax increase ever in the United States. However, the taxes would be in substitution of current premiums, not on top of. It creates a significant expansion of the federal government, and that's where you're going to see a big concern is, do we want the federal government to be managing all of healthcare, or do we or do we not? Do we feel comfortable that that's the right place for that to be, or do we like the private plans better than having the federal government? So those are things that we as individuals and our representatives need to think about. It's not just a simple answer of yes, let's do it, no, let's don't do it. So, as I mentioned, these are the people who are up for our area. Adam Kinzinger, the Republican, and he's the incumbent, and he is came out in the newspapers the last couple weeks, and his ads say repeal and replace. That's his answer. Sarah, I expect she spelled her name wrong. She only got one D. Sarah Dady is coming out in the newspaper saying Medicare for all. So those are their positions. Again, not saying one's right or wrong, but that's kind of what's happening. The other representatives we have at a federal level, neither one are up for election this time around. So we're not hearing anything necessarily from them. Okay. Do you want to ask questions about the federal before I go into state?
I don't know where to start.
You don't know where to start.
Yeah,
You
exactly.
do talk
Right?
fast. You do talk fast.
Okay, I was going to say, if we want
to separate them out. Most other countries that have a single payer system of some sort have a private insurance system in addition to it. And you have the choice, you can stay with personal or you can pay the extra to do that. Why is that not part of this discussion?
Actually, when I gave that list of the 4, like Medicare X, et cetera, some of those options did have that as one of the options to where you could either buy into the Medicare system or you could keep your private insurance. So the original.
But what I'm saying is they run both.
Right, and that's what I'm saying, that one slide that had 4 options,
Yeah.
the 4 that I didn't go into the detail, some of those options actually allowed for that. So that's why I think we went from, we're doing it this way to all the way to single payer, and now we're hearing some trickling of different options in between. So, again, a lot of this is not fleshed out, so, but they're sketchy. We think this, but they don't have all the details. The 2 that I gave more detail are the ones that have really put a lot more detail to their recommendations, so.
And
Yeah.
one other question with that. With the pre-existing conditions, if it is how it has been described in the last year, this is it as a woman, to know that the chance of getting pregnant is a pre-existing condition, how is that, has that changed? Is that still what is being said? Is that because it immediately all women who are, have a pre-existing condition from day one on, forever, so what does that mean?
These were women. So, they really didn't change anything with that.
Okay,
That's
so
still.
that's still,
yeah.
it is still
Yeah.
considered a pre-existing
Yeah.
condition.
Mhm.
Okay. Yeah.
The sign up, the enrollment process, I heard it's been shortened.
Yeah, it's not, I don't know if the actual number of weeks have been shortened, but what they've done is they've decreased the funding for the navigators. So the number of people available to help someone to do it has been very limited. And the other thing is, when you sign up on this website, they've actually scheduled maintenance downtime of the system
During the enrollment.
during the middle of the
Yeah.
enrollment time, which they actually did last year as well, is what I read. So, but yeah, so that's been a difficult challenge with it as well. Is there's current administration is saying, well, you can still have it, but maybe it's not as easy to get to it.
And it starts when? November?
It's coming up pretty soon, and I don't know the exact date. I'm not signing up for Medicare, so I don't know yet. Yeah.
To what extent has the AMA weighed in on this?
The AMA, I read an article today, the AMA is not for the single payer system at this time.
Of course.
How about the American Hospital Association?
American Hospital Association is has not weighed in one way or the other. I think that one of the things that, from a hospital perspective, many hospitals lose money on Medicare. They lose money on Medicaid. So in the current system, the way it's set up, they make their profit, their margin comes from private insurances. So if we're going to move to something like that, then how do we ensure that the hospitals at least make their margin and enough money to be able to continue their mission?
Yeah.
Because you got to have money coming in, or you can't be buying new MRIs and CTs and all these things you need to do to take care of patients. You have to be able to have enough sufficient money coming in. So right now, most hospitals do not make a margin on Medicare and Medicaid. Now that's one of the things we have to figure out is, are there ways enough? Is there enough ways for us to reduce costs in healthcare to get to the point of making money on Medicare? That's a big challenge.
To your knowledge, has Kinzinger ever advocated anything other than get rid of the Affordable Care Act?
I have not heard him ever say anything other than that. I have heard him say he does want to keep the pre-existing condition protection.
But he hasn't introduced anything or signed on into anything?
Not that I'm aware of.
Okay.
Somebody else might be aware of something that I'm aware of, but everything I've read was, I've not seen it come out on anything.
Sorry, unless it's more of a comment, what continually gets lost in all the discussions is that the cost of not doing anything, no matter what it is, getting rid of the affordable care is going to put us back to uninsured, and the cost of uninsured people was killing us. So in the whole discussion, nobody talks about that versus what the difference is or where we're going to. It's all like, if we don't have it, we're going to save money. We're not.
Yeah. So, you know, you asked if the hospital association. The hospital association is actually recommending we do tweaks to the current Affordable Care Act, not necessarily repeal and replace, and not necessarily Medicare for all. We need to continue to identify what those opportunities are, where can we do a better job, and then where can we continue to find opportunities to reduce the cost. So I know many of you were here at many of the other times I've spoken. We talked about the accountable care organizations. So we are actually seeing a reduction in the cost to Medicare from many of the accountable care organizations. So continuing to put incentives for in helping us to figure out how to reduce costs, reducing burdens, reducing regulations. I have to give credit to the current administration from a reducing regulation perspective. They did actually reach out and ask people, what can we do to reduce some of your regulatory burden? And one thing for us is we, by regulations, have to review every single policy that's regulation policies. We have to review those annually. They actually reduce it to every other year. So they try to come up with something that could help us to reduce some of our burden. So the idea is try to figure out some of those things that could reduce some burden. I think there's a lot more opportunity yet, but there is some thoughts towards that.
I got lost in the discussion of 24/7 emergency care and inpatient provisions. And
So a hospital has to have 24/7 emergency care, and we have to have, as a critical access hospital, which is what we are, we have to have at least 2 beds available, no more than 25. So
for inpatient.
For inpatient, that's our current situation, and so the emergency and the inpatient is what we are required to have. Under this proposed Emergency Care Act, we could change from what we are today to being an emergency center, outpatient center, and not have our inpatient beds. We would still have to have the 24/7 emergency access. We could still have the surgical access, still have the outpatient access, so you would still have your clinics and your MRIs and CTs and x-rays. You can have all that available in the community, but you wouldn't be allowed to have inpatient care, and they would actually pay us more for that than what they pay us now.
And their incentive to do that is something to do with funding, but what? If you don't have inpatient service, that's something that you're not getting funding for, or?
Well, so under current, we get paid for our inpatient and our outpatient. It's all based on the utilization, the cost of that care, okay? And what they're proposing to say is get rid of your inpatient. Inpatient is very expensive care.
Yeah.
And actually inpatient utilization is going way down because we're doing more and more things as outpatients rather than inpatients.
What's your average daily inpatient census?
Right now, we're at 7.
7? And you have 25 beds?
We have 25 beds available during flu season. We use
You
that.
fill up? Okay,
But normal day is 7.
okay.
So 86% of the work we do is outpatient. And that's not just because, obviously as a critical access hospital, our ratio is definitely higher than what an OSF in Peoria is because they've got the tertiary care component of it. But in general, even that, the inpatient numbers are going down as well.
If that were to occur, we'd be at St. Margaret's or IVCH. Or hospitals.
Yeah, right. We'd be transferring somewhere for inpatient care if we were to do that. Again, if they pass that act, we're not required to do it. We would have the option to do it.
Okay, thanks.
Okay, let's talk about the state. Okay, so I started out actually not talking about the Affordable Care Act's impact, so I'll do a little bit of this first, and then we'll get to Medicaid expansion, which is what came from the Affordable Care Act. So one of the things that we have in our state is we have, first of all, I should explain, Medicaid is funded 50% by the state and 50% by the federal government. So whatever the state needs to spend, the federal government matches, and that's how they pay their Medicaid bills. So in Illinois, we had a program that's called the Hospital Assessment Program, in which hospitals paid in money so that the state would have more money to pay back to hospitals, because then the federal government would match that money. So it basically increased the pool of money available to the state to pay their Medicaid bills. The way that program was set up is certain hospitals were exempted from paying that tax. And Perry, as a city-owned hospital, actually is exempted from paying that tax. But yet we got money back from that tax based on the number of uninsured Medicaid type patients that we were taking care of. So it's called an assessment program. We were assessing a tax from hospitals and then using that to boost up the federal funds coming into the state in order to pay for the Medicaid care we were providing. So that's what kind of basically the program was. But that program sunsetted this year. And so our Illinois Hospital Association worked with the Medicaid program in the state along with our legislators to put a new program back in place so that we could, because otherwise we were going to lose a lot of these federal funds that we were getting because of this program would be going away. So we have a new program put in place. The original program was based on this formula from basically 2005. So the amount of Medicaid you were serving back in 2005 was still determining how much money you got from this program in 2017. So they've now updated this program. It's based on a more recent formula, and it is also more driven to, as we see shifts in the percent of Medicaid in the market, that money is going to those hospitals that are taking care of more Medicaid. So a little more in line with where the care is currently, but it still allows for that extra funds to come to the state from the federal government. So that's what this hospital assessment program is. Part of reinitiating that program, they are doing what's called a hospital transformation. They put some funds into that. And what that is helping to identify, and my next slide goes to this. This program is helping to look at how are we delivering healthcare in hospitals in certain areas or where we have challenges, and how can we change that? So some of the funds are going into that transformation. So there is a task force